After inserting the Doppler probe all the way into the rectum, the surgeon starts to look for arteries at a depth of 4 to 6 centimeters. Here, careful attention is required. The handle with the probe attached is turned slowly until the first artery is detected and then held in this position. The depth of the artery can now be seen on the display. A 5/8 needle from AMI is placed into the needle holder and then inserted into the probe. The surgeon then ligates the respective artery through the ligation window into which the mucosa is falling. Due to the rectal blood vessels frequently changing their course, it is vital that the ligature be placed as close as possible to the Doppler ultrasound. A second stitch usually follows the first. Subsequently, the needle is cut off from the suture, and the two suture ends are knotted together. The result is a figure-of-8 knot. Now the handle is turned slowly until the next artery is detected and ligated as before. This continues until one complete rotation has been made and all arteries ligated. In most cases, 5 to 7 arteries will be found. However, this can vary considerably from patient to patient and may also depend on the severity of the hemorrhoids. Subsequently, it is advisable to pull the handle back 1 to 1.5 centimeters and to make a second round of ligations on this plane. The result of these ligations is a reduced blood supply to the hemorrhoidal cushions, and hence a far better balance between the inflow and outflow of blood. In time, the hemorrhoidal cushions shrink and the success of the therapy is evident some 6 to 8 weeks after, when they are back to normal. The mucopexy can also be performed with ease using the AMI HAL Doppler system. The handle is moved to the starting position used for ligation. The ligation window and hence the handle point to the position requiring treatment. The RAR flexi probe must be inserted into the rectum in such a way that the prolapse can be lifted to maximum effect. If necessary, the mucosa can be pulled gently into the RAR probe after making the first stitch to allow more proximal placement of the second one. By successive turning of the handle, more and more mucosa becomes visible. Proceeding step by step is important to prevent all the mucosa falling into the probe's ligation window at once. Continuing in this fashion, the surgeon places a running suture which ends between 5 and 10 millimeters proximal of